So, hello everyone, good morning or good afternoon, depending on which time zone you are connected to this IHE experience session. This session is the second part of a first one is the second part of a series that we have created in collaboration with the Global Consortium for e-health interoperability. There was a first session earlier today where we mostly presented what the Global Consortium does and the various implementations around Europe about the smart vaccination initiatives, or how they call it in Europe, the European COVID vaccination certificate. Now, in this second part, the idea is to try to expand a little bit the scope, try to see how IHE could support all those initiatives as member of the Global Consortium, obviously. And in that sense, this session is split into two main parts. The first part is trying on emphasizing a little bit on the role that IHE as an entity could have and already has, trying to support the various instances and initiatives on that topic and use case. And the second part is to present the developments related to several of the initiatives. We won't be able to present probably all of them, but I hope that we have been able to see the major ones outside Europe, which was more or less presented more in detail in the previous session. So, and then of course we'll have some time, hopefully, for questions and answers and have a short discussion at the end. So, wishing to start this first part about the role of IHE, I would like to invite John Moehrke, who is, and he's still the ITI chairman on the technical committees, and the idea is to see your view, John, on how we can support all these efforts, especially those that are already related to IHE profiles, but maybe even those that are not fully related to IHE profiles. So, John, the floor is yours.
Excellent. So I've been asked to present, let's get the one slide that I have available. I've been asked to kind of present in what way the IHE process and from start to finish really can help with, for example, the COVID vaccine credentialing certificates efforts. So what I want to really discuss is the general process, which I have a presentation slide here from a while ago, but the process hasn't changed all that much, while expressing that there's particular points in here that provide opportunities to use the system to bring harmony, and other points in the process that enable speed and enable accuracy and the ability to promulgate and move forward. So the thing that's potentially not going to be discussed a whole lot is the lower left-hand corner, the very start, which is presenting a use case. If we presume that the use case has been presented quite a bit already, we do need to focus on this point that the use case is important, not necessarily the solution to the use case. In that way, we can ultimately later on prove that the use case has been addressed. But we always start with the use case definition in terms of what is the desired outcome, what is the problem with the today's technology or today's interoperability specifications. The main place that I think really brings up the benefit that IHE has is in step 2 under identifying available standards. In this case here, it's describing available standards, but really the broader picture is that this point in the evaluation is also looking at, is there already in the wild implementations that can be shown to be comparable. And we've seen a couple of discussed implementations around the COVID credential. So this question then becomes, okay, what are these? What are their strengths? What are their weaknesses? What is their what do they deliver? Do they fully deliver on the use case? Do they deliver more than is necessary? So a very important step in the IHE process is identifying the available solutions. And the case that we have today, where there's a couple of solutions that are out there and they're starting to be used, is actually a good case for IHE, because IHE really wants to be able to evaluate actual implementations versus purely theory. So that's a very important point within the IHE process versus other processes. We then developed the technical specification, and we certainly are using the same tools, a common set of tools from a development of technical specifications with HL7. So this implementation guide publisher that is a very powerful tool to us now. It enables us to not just simply do as we have in the past, where we write the narrative with shalls, shoulds, mays, and the like, but it also gives us the ability to include into the documentation a computable form of those constraints. What would this? What are the constraints that this message encoding would need to convey? And more important, and in this case, we can also include working examples that we can prove are compliant with the constraints, which are compliant with the narrative. And those can lead towards understanding of the specification. My experience is they can lead to better writing of the specification because you see practical reality versus a theory. So this step of using the publication tooling to provide testing and examples. That then has two different potential places. One is product declarations and implementations, and the other one is setting up towards testing. And that's not really represented all that well on this slide deck, but I think it's a very important point that just simply is missing in this deck. I apologize for having pulled it together at the last second. But the idea of transitioning from this computable set of constraints into testability using test tools that can understand those constraints, test tools that can be proven against the examples. You can then have some automatable steps that can be done outside of a connectathon, and therefore at the connectathon, you can spend more of the energy on the overall flow from start to finish, as opposed to this particular point and this particular point and this particular point. And then, as that happens, you then start to be able to bring in public comment, bring in experience, which then can go back around with that cycle again. We support, multiple revisions. Some of the work I've been involved in is on its 4th revision, major revision, while still in trial implementation. So, we can absolutely learn and evolve and learn and improve. So I think bring it back to the point is that the IHE process fits very well with picking up a use case like the COVID credential. It is a positive way to bring some harmony, select some alternatives, select from some alternatives, potentially select some alternatives, and then through the use of the implementation guide publishing, have examples, have potential open source implementations that can show conversions. So one of the things that has been discussed is the International Patient Summary could be a source material for the issuing of a credential. Okay, can we produce some open source implementations that can take a well-formed implementation or IPS, convert it and the like, and then can we then publish that back into the exchange, so we can start to build and build and build upon that. I think that concludes my section.
Thank you very much, John. That was very nice. The idea was to present a little bit the way that we work, because in the audience, we may have people that are not aware of the efforts that we have been doing at least 20 years now in that domain, and with more complex, probably, use cases than the one that we are discussing today. Now, trying to move one step further, I'll try in a short presentation. Let me share my screen. I'll try to explain what we have been doing in IHE services in the last month, since the COVID pandemic started, and we started receiving requests for support and help by the different initiatives that are implementing solutions in the domain. So, yeah, I'll skip the part of the program. So as you know, in the last months, all the countries at the global level, they had to overcome some unprecedented scenarios, mostly trying to take care of the healthcare of the citizens, to try to fund the different developments in the therapies and in the vaccines. And most countries also did quick reorganization of the healthcare processes to be able to deal with what was happening. And in addition to that, especially in order to be able to reopen markets and the mobility of citizens at the global scale, new processes have been were discussed from the WHO initiative, for example. I think we'll have more information on that later in the session today. And the European Union did the same discussions. So it was key to be able to manage the vaccination cycle and the mobility of citizens. And the basic idea of this use case that has been so much discussed and so intense discussions in so little time. So the digital developments were so fast-tracked in the same way as the vaccines themselves did happen. So if you see a little bit what's happening, there are several digital vaccination certificates that have been implemented. Some of them are already live, some others are still on design phase. In order to be able to share certificates of vaccination or certificates of recovery, so that the mobility of citizens can be restored and the life, as we know, can continue. In order for this to happen, the role of IHE, in addition to what John described shortly before about helping in reorganizing the specifications and maybe even creating in the future white papers on how to better implement the different implementation guides, or even create new IHE profiles if need be. The idea was to see how we could reuse the tooling that we have that is part of the methodology of IHE to be able to test the specification before they are implemented in real life. So the idea is to have specifications that really work. So I won't go in the details of the different certificate initiatives. The three major ones that we know and that the more active around the globe is the one coming from the European Union, the EU COVID certificate, which in fact is a three-type of certification. It deals not only with the vaccination part, but also with the negative test results and the ability to move for the patients that have recovered from COVID-19. But if you see and observe the different use cases and the technologies, you will see that most of the use cases have been thought of in the same way around the globe with minor, let's say, changes. So that's the European one, which is very simple. And the idea is based on the European values that of minimum of sharing only the minimum sets of information that are required, respecting data privacy and also equity in moving around, at least in the European countries. So they have created this architecture with the digital certificate gateway, where in fact it's just a repository of public keys, so that from one country to the other, you can validate the validity of a certificate that has been digitally signed in another country. Similar case with WHO, more or less very much aligned on the architecture part with the European views, but much more detailed in the clinical scenarios and applied only to the vaccination cycle. At least this is what has been deployed in the first version that has been put for public consultation. And I guess we will hear more about the WHO propositions, which I think they are targeted for a global use and mostly for the low and medium income countries, which maybe don't have so severe or important infrastructure in place. The last part, the last initiative, but not the only one. We will see later that there are other initiatives that are much more advanced than the one that I'm just slightly presenting to explain the differences between the different initiatives that we have. Is the one coming from, it's a market-driven approach coming from the Vaccination Certificate Initiative, and we will have a presentation of that very well established in the United States initiative around the vaccination credentials. They have their own model. I won't go into details. We will let MITRE, who leads that initiative, to present it later on. Going back to the IHE world, the way that we see testing, as John mentioned, this starts from the proper organization of standards into integration profiles or implementation guides. We have now the tools to do that very quickly. As we know, interoperability is being deployed based on use cases. So the vaccination certificate is a typical use case that can be deployed within IHE. And then the specifications can be for sure tested at the connectathons and deployed by the different vendors that are testing there, but also can be deployed in what we call projectathons. And I think it's a good idea for you to watch also the specific session on projectathons this Thursday morning, if you want to learn more about projectathons. But as it is done in the European Commission, it can also be used for pre-production testing, so testing the specification before entering into production. So at IHE, with the test tools, we don't use the test tools anymore only for the connectathons, but we can use the same tools also for other purposes. Mostly we can divide the testing continuum into two groups, the one that are related to testing products, so the connectathons, the conformity assessment from IHE, and then testing aggregation of specifications or implementation guides that are related to specific implementation or projects. And then we are speaking about the other two aspects of testing. For all this, we have created a set of test tools, which is an open source platform called Gazelle that has been operational for at least 10, 15 years now in the different connectathons and in several implementations and national and regional programs. So we see more or less Gazelle to operate as an ecosystem of tools. So since it's a set of open source tools, we are collaborating with many other entities and we integrate existing tools. So the goal is not to create tools for everything, but to be able to integrate seamlessly in a way that it's very practical and easy to use for the vendor community to test in an environment they know, and just add new test plans and test scripts for them to use in the different use cases with the new integration profiles. So that's the overall idea. Gazelle is like the center of all for us, because you can implement and insert there all the specifications, and then you can use them at the various level of testing, either for project, for vendors, or for regional projects or national projects. Gazelle, as we said, is not a stable, something that is, it's something that we innovate on every year, and every year we have an innovation program that is funded by the IHE deployment committees like the European one, IHE USA and others, but also from large national and regional projects that have specific needs. So this is the way that every year we are evolving the ecosystem of tools of Gazelle, and it's much, much more complete than it was a few years ago. In that sense, we have been started developing some tools related to the smart vaccination certificates, and Dylan and the team will present this shortly, just after this short presentation. So trying to close this short presentation, the idea from our side is to be able to become a supportive organization in that specific use case as well. Try to help the different initiatives to align themselves where that can be achieved, or learn from each other if that's possible, and also create consensus and help them to leapfrog towards adoption and implementation where that's possible. IHE works with a very wide ecosystem of vendors that are participating in the connectathons. So bringing those specifications to the vendor community is something that increases adoption and maturity on those specifications. So yeah, the overall vision would be to create an instance of Gazelle that can be reused by any initiative and by any country in the world that would like to implement the specifications that are based on the initiatives that we can host their specification. So the one that we mentioned, but potentially also more than those, as we said before. So with that, I would like to thank you, and I would like to give the floor to Dylan to explain a little bit more detail what is the instance of Gazelle, the sandbox that we have created, and we are currently working on and expand it day by day with the support of various non-for-profit organizations like OpenMRS and OpenHIE. Try to achieve that goal to be able to serve any type of implementation, big or small. So
yes,
Dylan.
Thank you, Alexander. Okay, so I'm going to share my screen. Okay, there you go. So yes, so the testing tool for Gazelle Vaccination Passport demonstration I'm going to show. We focused in this initiative with MITRE and OpenMRS on some particular specification, which is the Green Pass, the one European that Alexander just talked about, based on their trust framework architecture solution. which is actually inspired from Google and Apple as well, initiative they've done in the past. And the overall idea is that we focused in this particular sandbox some tools and some exchange with MITRE and OpenMRS to already start this initiative around the vaccination passport. So we focus mostly on the offline verification of the workflow, which is the first part that will be implemented for the UE DGC solution, or the DCC now. They renamed it to Digital COVID Certificate now. So that initiative implies some standards and interpretive testing that we want to achieve with Gazelle testing tools. So we are going to cover HTTPS standard over private network exchange between national connectors and the gateway, the DGC gateway, so using MTLS. So that's the current context of what we're going to start with our validation. And as well, we're going to make some simulators as well, some simulation around this. For the security data exchange, the standard uses CMS using signed data based on the 64 format. And the essential data that will be exchanged will be UTF JSON schema that will be used for the distribution between the DMS. Some new standards as well as to be integrated, CBOR and COES, which are some other extensions around Jose standard for the 2D QR code, well, the QR code generation, not only the 2D QR code, or the data matrix generation using some specific standard for the compression as well. And all this is in the context of course, exchanging FHIR message. So the first time we're going to talk about minimalize the data set from the specification that European has started working on. So it's not a complete FHIR bundle that was going to be changed to QR code, but a minimal data set with the COVID and the PCR test and the recovery information. So what do we expect from Gazelle? We're going to verify and validate, verify the crypto materials in the context of the specification of UDGC. And the validate is we're going to use our validating tools, plus we already started some prototype that we're going to demonstrate over the QR code. So what we're going to cover is ATNA that we have already, X509 startup certificate as well. We already have a past experience with HDSR DGC. We use a trust framework based on certificate, and we're going to focus on extending this in the context of the vaccination passport. So that we give an example of different ITF specification here that we are going to work on this initiative. So the demonstration of our testing tools, we're going to use the VS client in this sandbox for OpenMRS, which is our central service validation tool, that provide the GUI and web services. We have for the trust framework part of this specification of UDGC, we are going to use Gazelle Security Suite, or GSS demonstration that provides simulator and validation around certificate, X509 certificate. We have as well other tools, of course, the Gazelle proxy for the medical records. You can capture message. We have Gazelle FHIR validators as well that we use to validate a resource based on standard structure definition and implementation guide. Gazelle Web Service Tester and Inferno testing tool integration with MITRE are the FHIR simulator side that we use in this sandbox. So that's for testing both the crypto materials with GSS and for the trust framework. And for the medical records, we're going to use our current validators, FHIR and other, like the simulator for Gazelle Web Service Tester. And of course, we have our prototype around QR code that we're going to demonstrate. So that will be split in two demonstrations. First demonstration around the VS client with GSS and more. And the second demonstration will be around the QR code. So I'm going to give the hand to Nicolas. I don't know if Nicolas, you were present in the context of presenting this OpenMRS platform. Okay, I can't hear Nicolas. Okay. So what I'm going to do, I think we have some issue with accessing the OpenMRS platform. I don't know if you can see my screen right now for the first demonstration.
Yes, we can.
Okay, so I'm going to show you the AVS client is the central service for validation we have on the sandbox of OpenMRS and IHE. This one is actually
Dylan, just
the
central.
Yes.
I just gave Nicolas the right to
Yeah.
speak. So.
Can you hear me now?
Yeah, great.
Oh,
Yeah,
perfect.
okay.
Perfect. Yeah, I couldn't unmute myself. Very sorry. But well, I can share my screen then, Dylan, if you want.
Yes.
Oh, I hope you can see. Can you see my screen now? Remove that. Okay.
Yes.
Okay, perfect. So this is the IHE OpenMRS platform we are using as a sandbox. So we have several tools installed already on the platform. As Dylan already mentioned, we have Gazelle Security Suite used for generating certificates. We have an embedded certificate validator, and we have as well other things for the ATNA profile. We are using as well the Gazelle Fire Validator tool to configure fire validators. At the moment, the validators inside this tool we have already configured are based on structured definitions from the IHE GitHub, but we can as well use IGs that are loaded on a Happy Fire server. We have Gazelle Web Service Tester, where we can upload SOAP UI projects. We can there see the exchange messages, and we can as well call the remote validation from EVS client. And we have finally EVS client, which is the front end with all the validation services configured. So I'm just going to go onto the tool. There we have already configured the certificate validator and the fire validators. So I'm just going to go real quick on the validation logs, where I have already performed some validations from a certificate generated on GSS. So it's our own certificate. So it's just the validation is only based on the X509 standard. So I'm just going to show you one of the reports we have already. So this is as well the file content. And then just going to go back onto the fire validations. We have configured some MHD IHE validators. So based on the one we have configured in fire validators, sorry. And then here is a response we have taken and that we have validated. So here is the report. And we can as well go onto SOAP UI, onto Gazelle Web Service Tester, sorry, where we have all the SOAP UI projects loaded, where we have already as well executed it. So these are only Swiss SOAP UI profiles, so it's not linked to the IHE validators we're using, but then we could as well, so this is an execution of a SOAP UI profiles with messages from the Swiss project, and we have already done a validation as well. So we can still access the link, and this is some MHD messages as well, so a bundle. And I'm just going to show you as well real quick the validation. If it, yeah, okay, all good. So yeah, this is failed, but only because it's a Swiss project. I'll let you, Dylan, go back.
Yes, thank you, Nicolas. So maybe now you can show the prototype we've been working on. With Cedric for the QR code validation.
Yeah. Hi everyone. Do you hear me?
Yes.
I cannot share my screen. I cannot share my screen because I'm a participant, Dylan.
Alexander, you're one of the hosts. Would you be able to promote Ewan?
Yeah, can you give me a right for share my screen, please?
Yes, I've got no right.
Yeah, I just did it.
Yeah.
Okay, yes, so okay, can you see my screen?
Yes, we can.
Okay, good. So I'm going to show you the solution we have developed for validate the digital green certificate. So we are in a VS client. It's our tool for validate messages. And we can find the new validator, DGCG. So it's a validator for the QR code. So here we can upload a QR code. It's a PNG file, and we validate it. And so we can retrieve the validation report. So we can see that we are different elements that we are checking. And we have a different level of priority we are checking. So we are checking the QR barcode validation with a different type of priority. We are checking encoding of the QR code, compression of the QR code, and the signature of the QR code. And at the end, we have the QR code, which is displayed. And so we can retrieve it in the list. And it's a prototype that we have developed for give a solution for the digital green certificate. And that's all for me, Dylan. Do you want another thing?
Thank you very much, Yoon. Dylan, I think we have completed.
Yes.
Even more than expected. So thank you very much for this. So the only scope of this was to show the powerful tools that we can use and that we are currently working on it. So it's not something that needs a huge amount of weeks and months to be implemented. It can be implemented as the specifications are created. So with this, I think we can conclude this first part, and I would like to give the floor now to Amit to handle the second part of this session.
All right. Well, thank you, Alexander, Dylan, and John and Yoon for the demonstration and the presentation. Now we'll start our next portion of the program. And so, hello, my name is Amit Trivedi. I'm the Director of Informatics and Health IT Standards at HIMSS. And on behalf of the Global Consortium for eHealth Interoperability, HIMSS, HL7, and IHE International, as well as IHE Catalyst, welcome to the concluding session for today's program, Current and Future Steps of the Smart Vaccine Initiatives. What's next? And so today our invited experts will be sharing their unique perspectives based on their involvement leading the technical development and implementation of standards and infrastructure, making digital vaccine certificate schemes and sharing of that information a reality. And so please chat any questions you may have for the moderator, who will be wrapping up this session with Q&A after each of the presentations. And today, the rest of the session, we'll be walking through different presentations, starting with Natschja Ratanaprayuin, the technical officer at the World Health Organization. She'll be speaking about WHO use cases and specifications for vaccination certificates. She'll be followed by Jen Antilla, the OpenMRS Director of Community, and she'll be speaking to digital health, leveraging global public goods to fight COVID-19. Neelima Karipineni from MITRE. She's the lead clinical digital analyst at MITRE. She'll be speaking about smart health cards for vaccination credentials. She'll be followed by Rob Hausam and Giorgio Cangioli from HL7, the International Patient Summary Project co-leads. And they'll be speaking about the specification as a foundation for building global vaccination certificates. And finally, Rajeesh Menon will be wrapping up the set of presentations, speaking to the digital infrastructure for vaccine open credentialing, DIVOC, and his unique perspective, having issued over 250 million credentials already through the program. And so with that, let's start with Nat's presentation, if we can display that and get that started. So thank you.
Great. So can everyone see my screen?
Yes.
Great. So hi, my name is Nat. As Amit mentioned, I'm a technical officer in the Digital Health and Innovations Department at WHO, and I'm helping coordinate what was previously called the Smart Vaccination Certificate Working Group. Work is now the Digital Documentation of COVID-19 Certificates work. So maybe to go back to the use case, I think it was really interesting to note that Alex had noted that the use cases are very clear. And I think it's really important to understand from the WHO perspective how we're actually looking at the use case of vaccine records in a digital form. So taking the digital out of it, vaccine records are really an important tool for vaccine programs. So the primary use case that WHO is very much interested in is the continuity of care piece. So it's being able to ensure that people know when their next dose is, what dose they need to obtain, and for the health worker to also know what next doses the person would need to have, and as well as adverse events reporting. So if someone does have an adverse event, then they're able to accurately communicate to the health worker exactly what vaccine they got, which batch number, when, where, to be able to do that proper investigation to adverse events. And then the second use case, which I think is probably more of the hot topic of the day, is really that proof of vaccination. So using vaccine records as proof of vaccination isn't really new. It's been used previously for work, health insurance purposes, for education, and of course, travel with the yellow fever vaccine. And I think in regards to the COVID vaccine specifically, I think this is where a lot of the discussion has been for international interoperability, is for cross-border travel. But I think it's important to note that as WHO, we also still very much care about the use case of continuity of care, so that if someone does get ill while they're abroad, then the health worker can appropriately know whether or not they've received the COVID vaccine, for example, and understand if they're still at risk of getting sick from COVID or any other disease. So I think just to lay that groundwork. The other addition to note is that at WHO, we really see the documentation of COVID vaccination status as part of a larger ecosystem of digital tools to support the immunization program. So obviously there's much more to delivering vaccines at scale than just documenting people's vaccine status. There's also safety monitoring, supply chain monitoring, counterfeit detection, microplanning, and things like that. And so this is really just to show that the vaccine status is really a small part of a much larger ecosystem of digital tools that WHO is looking to provide guidance on. So going specifically to the vaccine certificate, I'll explain in a bit why we changed the name, but for ease of understanding, the vaccine certificate really is a medical document that's managed by public health authorities within member states. And I think that's important to note the distinction we're making here, because a lot of the media, you'd see it refer to vaccine passports or passes. We were very intentional to not use that language, because it's really about how to document that this vaccine event has happened for a person in an accurate way in a digital format. And so it's not so much about a judgment of whether or not someone could cross a border or not. It's really for the purposes of that individual having access to the records. And so our guidance that you've seen in the release candidate 1 document is really based on existing home-based records guidance, which are common for childhood immunizations, as well as the International Certificate of Vaccination Prophylaxis, or more commonly known as the yellow card. And so the way we wanted to go about doing this is to ensure that it is an equitable specification. So what that means is that it can be purely digital, but we're also going at this with a paper-first approach that can have a digital representation on the back end of that paper record. And so this is just the reality, is that most people, I think most people in this call probably have a smartphone, but most people in the world do not have a smartphone. And so we have to be very cognizant of that constraint that we're working with. And so again, the vaccine certificate in Release Canada was really focusing on the vaccination event. But obviously, as more science comes out to support reduced transmission, or if the guidance supports introducing the vaccine certificate as a pass, then we'll update the guidance accordingly. So with that, the reason why we changed the name to Digital Documentation of COVID-19 Certificates, which would include vaccination status, but it has also been decided that we would release guidance on COVID testing, so SARS-CoV-2 test results, as well as recovery status. And so the reason why we want to do this is because the fact is that vaccines aren't equitably distributed across the world right now. And so countries are looking to test certificates as well as recovery status certificates, similar to what the European Commission is doing as a means to promote travel across borders again. And so what this means is that the DDCC is really a digitally signed FHIR document that represents the core data set for the relevant COVID-19 vaccine certificate or testing recovery status certificate using the JSON representation. And so the expected outputs, I think the biggest thing that has changed as well for this work is that WHO will no longer be establishing a global health trust framework. I think as Alex had presented there in the RC1 document, we did intend to set up a global public key directory. And I think from the technological perspective, it's quite straightforward. I'm not a software engineer, but I understand technology enough to understand that public key infrastructure is something that has been used widely globally for a long time. And talking to regions, for example, in the European Commission, as well as the African Union, they are adopting that technology. But when it came down to WHO establishing a global mechanism for verifying and validating vaccine certificates, that really more spoke to the governance questions that haven't been figured out yet by member states. And as a member state driven organization, it was really important for us to ensure that we do that the right way. Just to kind of highlight some key issues that came up, there was the issue of devolved nations, and they wanted to have their own national public key infrastructure that would host their public keys with WHO. Obviously, from a technology perspective, that's definitely feasible. From a governance perspective, when a country isn't necessarily considered a member state within WHO, it's a bit less clear what exactly should be done there. So that's the biggest thing, so that we're deferring that, not necessarily not doing it, but for now, it's kind of pushed out so that we have more time to have proper member state consultation. But going back to what WHO will be producing is that we will have specifications documents for the vaccine status, SARS-CoV-2 test and recovery status. They'll be released as either 2 or 3 different documents, simply due to the fact that a lot of work has already been done with the vaccine certificate, but they'll all fall under the umbrella of the DDCC. And then we'll also have a high-level implementation guidance for establishing national trust frameworks embedded within each of these guidance documents. Again, high level in a sense where we understand that each member state has their own context and way of working, and we don't really want to restrict countries from doing any of that. As always, WHO will also be providing country support with an example implementation based on the FHIR IPS, as well as technical support to LMICs, financing through the COVAX mechanism, and lastly, a global vaccine product registry that has a canonical and coded list of all the vaccine products. So what will be in the guidance document is really, there'll be business processes and workflows and use cases, core data elements mapped to code sets, functional, non-functional requirements, and a very high level overview of what would be required to sign a digital certificate without going into the details of how it should be implemented. A FHIR implementation guide, which would be a linked website. I think everyone here is familiar with the FHIR IHE, as well as data protection principles, ethical considerations, and national governance considerations. So in terms of assumptions for WHO, we'll recommend the minimum data set and such, as I just described, as well as an example implementation. But it will be up to the member states to choose which modalities they want to implement the COVID certificate, so the paper, smartphone application, what point of service solutions they want to use, which softwares they want to use. They'll also be responsible for implementing the necessary policies and the legal basis to support these implementations, as well as which trust frameworks to use. So this could include having a national trust framework, but they could also establish bilateral and multilateral agreements. And lastly, the one that I think is a hot topic for most people is the mechanism for unique identification. So going back to the fact that in our view, the COVID certificate really isn't an identity document. We're not requiring identity binding in order for someone to receive a COVID certificate. And so that's pretty much a high level overview. Happy to answer any questions, but any detailed technical questions, I might have to defer back to my team, but that's all. Thank you.
Well, thank you, Nat. That was a great presentation. And let's collect some questions in the chat, and we'll circulate them to the speakers so they have some time to compose and respond during the Q&A after that, if that works. So please keep those questions coming. And then let's move on to our next speaker. I believe that's going to be Jen.
Thanks, Amit. And thank you everybody for being here with us today. I actually feel like a lot of what I'm going to speak to today simply builds on, first of all, the wonderful work that and framing that Jan Flowers put together last March, but also what we heard from Nat and Alexander earlier. So in the next 10 minutes, I just want to briefly talk about the low and middle income context where these solutions are being implemented, and how COVID is affecting them these days, a very special emphasis on those responses, and then the global goods, public goods approach, and just focus on a couple of current global good COVID-19 initiatives that are of particular interest to this group. So let's start with a little bit of a reality check. Some of you may have seen this already. Some of you may be familiar with low and middle income country realities, but these systems that we're talking about, these COVID-19 digital solutions and global goods that we're implementing in these countries are not simply placed in a clinic in a vacuum. They're deployed in very challenging settings, and trying to really respond to the complex needs, healthcare needs of many vulnerable populations. So this is kind of the situation already without a pandemic going on at the same time. So think about what you're seeing here and consider, in this setting, how would you provide consistent, high quality care in this reality? And as we saw in 2014, 2015 with Ebola, and this year with COVID-19, how would you then go about stopping a pandemic when you're already dealing with these challenges? And when it comes to health information systems, health systems, there are additional unique challenges that these countries are facing on a day-to-day basis, right? There are limited developer resources. So this means that oftentimes there may just be one or two developers in a country that know the technical architecture. There are many different partners implementing solutions, stakeholders funding different solutions, all with the same aim of trying to improve access to health information and improve patient care. But how do you coordinate all of these efforts? How do you make sure that there isn't duplication of effort and that funding is being used efficiently? And all of these problems are actually compounded as COVID emerged and people tried to really respond to the pandemic. So let's take a look at what actually has been happening with COVID in these low and middle income settings. So early on, we saw a much faster public health response. Even with global digital goods, we saw people really come together quickly and try to work on solutions that would really address those initial needs, health information needs around COVID, around contact tracing, and screening and such. The good news, and this is definitely a mix of good news and not so good news. COVID has had a somewhat less of an impact on low and middle income countries. Their populations are relatively lower, even though there is underreporting of infections and deaths. But the challenges that we're seeing now mean that the likelihood, especially as we're seeing in some specific countries, like this week, this month, today, is that the chances are that the burden of the pandemic will actually be prolonged because there are challenges accessing and delivering COVID-19 vaccines and therapeutics. Financing for vaccines and therapeutics is challenging. And even just identifying who is eligible and ensuring that those people who are eligible for care and for vaccination actually receive those services is challenging. So let's go back to a little bit of good news. Unlike in 2014, 2015 with the Ebola pandemic, this time around, digital global goods are actually in a much better position to coordinate our work together and much more in tune with what countries actually need, from improving data collection and access to high quality data, to reducing the multiplicity of systems and addressing the human resource gap. And especially, as we heard a little bit earlier, about supporting the care cascade or the continuum of care across sites and borders. So, if you look at this diagram here that I'm showing on the screen, you can see how different global digital goods, from CommCare or Community Health Toolkit, focusing on data collection and reporting from the community, contributes to the COVID-19 care cascade, even to the role of OpenMRS and OpenELIS in managing very specific health data needs at the facility. And specifically, as we're talking about vaccines, talking about vaccine history, tracking, making sure that clinicians are aware of those adverse events and know, which of their clients, which of their patients have been vaccinated or are due for a second dose. And even, then sharing that information, sharing that data with global goods such as DHIS2 aggregate or SORAMAS. So we're actually in some ways in a much better position than we were 5 years ago when we're trying to respond to COVID-19. And that kind of is because we're really taking this a more coordinated global public goods approach, where we recognize, I think many of us working with different global goods, particularly at OpenMRS, that we will go a lot farther together. And we will be able to have more continuity, more sustainable solutions if we pool our knowledge, and we can actually avoid a lot of duplication of effort and have more robust solutions if we are able to replicate what works and reuse and extend what perhaps we already have in place for regular healthcare and apply it to the pandemic. This does mean that we have to be a little bit more intentional with how we're coordinating and how we're collaborating together. So there's a greater demand for community engagement and shared decision-making, really making a purposeful effort to identify solutions that can be reused and improving on them. And then standardizing a lot of these processes that we're using to develop these community-driven digital public goods solutions for COVID-19. And really through all of this, we're hoping to answer some of those questions that many global digital goods are asking right now about how can we be sustainable, how can we diversify our funding, and how can we quickly support people working on these solutions, knowing that we're often using a community process that requires a little bit more time to plan our collaboration. One of the bedrocks of all of this that really has facilitated digital global goods ability to respond to COVID and to actually any of the needs for providing an interoperable solutions has to do with standards. And this is where I particularly want to call out the role of the OpenHIE community, that really they have an architecture specification that is really kind of based on that foundation of HL7 and fire standards and IHE profiles that, and then what they put in the architecture specification really kind of sits on top of that. And I think that has particular implications for the work that then point of service systems like OpenLS and OpenMRS can do. So here are a couple of examples of what two global goods in collaboration with OpenHIE have been doing in regards to COVID-19 and specifically using fire. So OpenHIE and OpenMRS have been supporting, have figured out some support for IPS for immunization records, which is critical to tracking COVID-19 vaccine, and then incorporating the smart vaccine certificates. And meanwhile, OpenLS and the OpenHIE architecture are in Mauritius are supporting inbound passenger registration on arrival and national laboratory testing, referral testing workflows, and contact tracing. So this has kind of been the context for a lot of the work that different digital public goods are doing in low and middle income countries. And to just wrap up, I want to highlight that in all of this, if we focus on how data is used and how we can together can respond to the actual data use needs, the technology piece, which we know changes very quickly, becomes a lot easier. We really need to make sure that we're focusing on making data available, focused on how we're exchanging data and reusing smart, robust solutions, even though that this can be challenging. And then keep in mind, as always, like the permanence of the data that we're working with. And looking even in terms of sustainability in the long term, how we can continue to build that in-country capacity to take these solutions that we're building today and really advance country ownership of them. And that has to come from going from that one single developer who knows the technical architecture in their country to building a cadre of technical professionals who can do that and carry on the torch. And I think all of this together, the next time we face a pandemic, a situation like we have with the COVID-19 pandemic, we'll be in an even better position to respond even more rapidly in support of these countries and their public health response. Thanks.
Well, thank you, Jen. That was a great presentation, and really appreciated you sharing your perspective on global goods and the role that the OpenMRS and OpenHIE community is playing. Next, we're going to hear a little bit from Neelima at MITRE. MITRE is, of course, also leading efforts with the Vaccine Credential Initiative in the US. But they're also known for their strong support of the open source community. Folks who participated in IHE Connectathons in the past have likely used some of the tools that the MITRE team has supported IHE with in the past. So Neelima, thank you for joining us today, and we're looking forward to your presentation.
Great. Thank you so much for having me. My name is Neelima Karipineni, and as I said, I'm a physician and informatician with the MITRE Corporation. We are a US federally funded nonprofit organization that works on systems engineering projects for the public good. And one of these projects has been the Vaccine Credential Initiative. This initiative is a coalition of organizations that have basically volunteered their time and come together around advancing the use of the Smart Health Cards framework for vaccination credentials. The Smart Health Cards framework itself is a completely open source standards-based interoperability framework that, like the other, I'm going to be echoing a lot of things other people have said today. like the other initiatives worldwide, are meant to get digitally signed verifiable copies of people's data into their hands for use however they wish to use it, and with the focus on doing so in a privacy-preserving and equitable manner. The scope of the Smart Health Cards Framework and the Vaccination Credential Initiative is pretty focused on the interoperability needs to issue, share, and validate these vaccination records. Unlike the presentation we just had from the WHO, we are not really focused so much on the clinical aspects. We're not handling scenarios of adverse reactions to vaccinations or forecasting schedules. Our scenarios are really the ability to sort of open up the country and have people be able to safely return to public venues. We have a number of collaborating partners, different stakeholders in different areas. We have nonprofit organizations, some health systems, EHR vendors, payer organizations, and non-health IT tech companies. As Alex said earlier, this is a market-based solution. The US government, we don't have a centralized vaccine registry or immunization system in the US, and the federal government has pretty much come out and said that they're not interested in maintaining any sort of centralized infrastructure or making any sort of guidance or regulatory requirements for any vaccination credentialing system. So they've kind of left it up to the individual states and to the market. So this particular initiative is a combination of a lot of stakeholders who saw that what was happening is a lot of other organizations were coming out with closed proprietary solutions that were not interoperable and were causing a lot of fragmentation in the marketplace. We're not being done in a privacy preserving way. So we tried to kind of come up with a solution that was an alternative to that approach. And the Smart Health Cards Framework kind of is what we came together around. The participating organizations in the VCI have kind of committed to using this particular framework and to allowing their implementations to let the consumer use the digital wallet of their choice. They don't have to be locked into any proprietary solution, and also to make PDF or paper-based cards a first-class player, so they're not locked into a particular technology like a smart mobile technology. And here we say, this is a little bit of an older slide deck. It says over 300 participating organizations today, but I think we're in the 500s now. Some of the key principles we came—
that was a wealth of information.
Some of the key principles we came together around are, well, transparency. We've tried to operate in a very transparent manner. All of our specifications are openly available online, and the source code is all on GitHub rather. And if you find a bug or a typo, feel free to submit an issue and we'll try to fix it. And we've been very active on the HL7 Fire chat streams as well, trying to keep people engaged and let them know where the project is. The other key principle is privacy by design, and the Smart Health Cards Framework itself is built around the W3C verifiable credential standard, which itself has a high focus on privacy. It's designed in a way that the different actors in the flow, the issuer, the holder application, and any verifier applications are not easily able to track the movements or the data of the people, the consumers who actually are holding the data. And then, as I mentioned, we're trying to do this in a flexible and equitable manner, making digital and paper cards a first-class player, and also ensuring that the participants in the VCI have committed to making these credentials freely available to use and not requiring any kind of pre-existing transaction costs. Governance has been so far through a steering committee of representatives of a lot of the stakeholders that I already showed. We are in the process of kind of coming under the HL7 umbrella for governance and having both the Smart Health Cards Framework itself and the data model and the implementation guide come under HL7 for formal balloting. The public health working group has been helping us quite a bit getting those moving forward, and we're hoping to get on this September ballot. And I think I'm not going to say too much about these use cases because it's very similar to the other projects that we've heard about today. And I'm going to take a quick look at our two core specifications here. One is the actual Smart Health Cards framework for the verifiable credentials. And then we have a implementation guide for the FHIR implementation guide for the actual data model and data we would expect for this particular COVID-19 use cases and vaccinations and testing. This is a little bit of an older slide, but a lot of the issues that we list here are still issues that we're struggling with a little bit. In particular, the trust framework is it's been a little bit thorny. We are planning to put together a directory or trust framework for our own participants in BCI, the organizations that have committed to the principles that we've discussed so far, and can show that their implementations are compliant with our specifications and standards. And we're still coming up with the guidance and the process for how somebody would be listed in this trust framework. And it's a slow process. We are still also trying to come up with ways to support our individual state immunization registries. Like I said, we don't have a centralized registry in the United States, at least. So there are, I believe, 67 different individual states, cities, and territories that run their own individual registries. So this is kind of a very tricky thing to try to coordinate and make sure that the states who wish to participate are able to. The status of current implementations of the Smart Health Cards frameworks, people are a little bit all over the place. Actually, our biggest issuer so far has been the province of Quebec in Canada. They've issued a few million of these so far. The EPIC Systems has released support for their EHR to produce these for the health systems that use the EPIC EHR. But that was a fairly recent release, and it's up to the actual individual health systems to then implement it and get it up and running at their sites. So we're hoping people are getting in the process of doing that. The state of California just announced recently that they are going to be producing these credentials for their citizens. And I believe the state of Louisiana also has made an announcement that they're going to be supporting it as well. And just a couple of weeks ago, Apple announced at their WWDC conference that they will be supporting the smart health cards within the Apple Health Wallet too. So we're getting there, but not a lot of real world use to date. And I'm going to take a minute to just take a look at our two specifications that we have right now. One is the Smart Health Card framework itself, and our documentation is available online at this spec.smarthealth.cards URL. I'm not going to go into too much detail here. It works very similarly to the other initiatives that we've heard about today. The spec itself it's pretty short, straightforward, and from a technical perspective, I think very understandable. And that's a function of a few things. One is because we have no centralized infrastructure whatsoever. There's not a lot of description of architecture or infrastructure that's needed within the specification. Another is that when we had technical design considerations, or when we had different options that we came up with in the design of this specification, we usually went with the more implementable route. Because the needs for speed with this project, we kind of decided we're not going to debate too much about which is better, JSON LD or JSON. We're going to do JSON because people have experience with JSON, and that is going to get us up and running off the ground the fastest. And the other is that the Smart Health Cards framework itself is sort of domain agnostic. It's designed to be able to digitally sign and verify any clinical pieces of information. The actual data model for the particular COVID-19 use cases are in a separate, sorry, Zoom is not letting me switch tabs right now. There we go. In a separate FHIR implementation guide. This is our, this long URL here is our draft FHIR implementation guide for the the COVID-19 vaccination and laboratory use cases in particular. And we describe those further here on the homepage. Right now, we've only modeled out to the actual vaccination data and lab test results. We do have a prototype that we're thinking about releasing for the recovery certificates that the other international efforts are also supporting. And we are also working on taking this to universal realm. Obviously, we initially started it with US core, as we see here, but in the process of bringing it under HL7, they kind of made the suggestion that we should think about making it universal, which the biggest task to do that for us has been the terminology. So we are still working on a lot of the terminology, international terminology. Initially, I think, especially for immunizations, it was simple. In the US, we just used the CDC, CVX codes, but trying to figure out, terminology that will work cross borders has been much more tricky. And HL7 and GS1 and other organizations have been giving us feedback there. And we'd love to get feedback as well from the different stakeholders on this call. I think I'll stop there. That's all I wanted to cover. Amit.
All right, well, thank you so much. And again, another great presentation. And we definitely hear your call to action and hope folks on the call also hear that support is needed around terminologies. And that's a big challenge as folks are looking to move to the universal realm. Next up, we have Rob and Giorgio, folks who have actually helped develop the International Patient Summary, which is a key component of the WHO's vaccine credentialing strategy and scheme. So with that, Giorgio, I see you on the session. I'm going to hand off to you and hear from you.
Is Rob? I think is Rob will start. Yeah.
I believe.
Sorry, I have to get unmuted and I put my video on. So, okay. Yes, I'm going to start and let me get that. There we go. That should be better. All right. So thanks everyone for being able to be here and talk with you along with Giorgio about the International Patient Summary, the IPS, and about how it can be used as a foundation for building global vaccination certificates. So I'm a physician informaticist myself, and along with Giorgio, one of the co-leads of the HL7 IPS project, also a co-chair in the Orders and Observations of Vocabulary work groups. And I'm going to start us off with a few slides that will talk a little bit about the IPS itself, what it is, and a little bit about where it comes from, and how it's been put together. So the first points on that are that the International Patient Summary is a health record extract. It's tended to be a snapshot in time of a subject of care's health information and healthcare. It is, as the title says, it is a summary. And that means that it's not the full EHR. It's not, we're not trying to convey all the health information about a patient, in every data exchange. But what we're trying to do is provide a snapshot, a summary of relevant healthcare information that can be used is useful at the next point of care. And this is an international specification. The intent is to provide a generic solution for global application beyond any particular region or any particular country. And the initial scope of the project was, it was designed around the idea of unscheduled cross-border care. And so, that's that's still really the primary focus, and certainly applies to what we're talking about here today. But the IPS also was designed with the idea of being a baseline in mind. So it's usable also for other kinds of scheduled or unplanned care cases in various clinical care scenarios. So that's switch slides, sorry. So in order to do that, to put all this together, it's a collaborative effort. It's a cross standards development organization initiative. And you can see a list of some of the organizations here, and pictorial of all the different different groups that are involved. It's really quite a remarkable thing. We've brought groups, as you see, from SEN and ISO and HL7 and IHE and SNOMED and the GIC, the Joint Initiative Council, these groups all together. And of course, you can't really see it down here in the corner, but there's this little diagram of kind of how this all fits together, and this very nice pictorial that sort of, again, shows how, how these all work together to be able to build these specifications. So here you have the HL7, the IPS fire and CDA IGs, and IHE, working with those and all the other contributions. So it's been an amazing effort to put all this together and to have all these groups working, very nicely and well together to be able to get to where we are, today with it. And so, drilling in a little bit more on that, looking particularly at what we're dealing with today with the IHE profile and the HL7 implementation guide for fire. You can see basically the notion here is that the IHE profile utilizes the HL7, fire IPS-IG, also the CDA-IG for that matter, but I think we're focusing mostly on fire here today. But IHE takes the standards that HL7 has developed, and as you heard all of the excellent things earlier about how how the testing is done and all of that, and adds its own very important contribution to this. So again, it's part of our working together. So one very important point that we want to always try to emphasize is that even with all these different groups involved in putting it together and managing it, and the various profiles coming from both HL7 and IHE and all that, there is still only one fire international patient summary. And of course, that's true of CDA as well, but again, we're focusing on fire here. But in the fire context, what we do basically is, again, HL7 develops the implementation guide, and IHE profiles on top of that. And with the experience in the IHE Connectathons we're having this week, and other IHE implementation efforts, we gain experience, and that can provide feedback back to HL7 to further improve the implementation guide. And it's a continuous building process. And again, it's been a very excellent collaboration. So I think this would be the last slide that I have before I turn it over, but this shows a little bit more about how all these pieces all fit together. And so the IPS is a document. It's composed by a set of reusable profiles, and you can see those outlined here, and then also detailed down here. We have the individual profiles on things like the allergies and problems and medications. Those are the three required sections I think you heard about a little bit earlier. Also for vaccinations, or the immunization profile for that, and other items, other data elements like lab results and procedures and devices and others. And so we have the profiles on all of these that work together and can be composed into this document, or we also have the notion that I was mentioning before about some of those profiles can be used individually. So it basically forms a library of profiles, for building on top of, and that's what we're talking about in particular with the vaccination certificates. And so with that, I'm going to turn the rest of the time over to Giorgio, and he will talk more about how we use IPS, the IPS library as a foundation for building vaccination certificates.
Yeah, thank you, Rob. As Rob is the next slide, As Rob described, the idea of using the IPS not only as a single document, but also as a library led us to investigate some years ago the possibility of reusing the vaccination component or other component to build also other kind of document beyond the IPS. And in the Trillium 2 project some years ago, we investigated the case of reusing that component for global vaccination certificate like the yellow card. What is interesting is that now this is becoming real. Next slide. And what is also even more interesting is that, as you know, the vaccination now are not dealing only with the event of the immunization, but also with other information like test result or next, the recovery from the specific condition. So all this information can be as well be covered by reusing some of the components that the IPS, let's say, library make available. So looking into the global possible workflow, and I thank to Derek for this slide that was used last week during the JIC webinar. This is a typical case of workflow from the vaccination to the verification of the certificate, and where the IPS could help on that process. Next. So the first most obvious thing is that the IPS can be used for example, to check if there are specific allergy or if there are specific problems that may prevent or need to be considered when the vaccination is administered. But the next one, so when these vaccination information are available, then the IPS could be updated to be reused potentially for as a way to generate vaccination certificate for documenting the vaccination and the possible tests, but also for verifying the fact that this information can be trusted and can be used for crossing a border or for accessing a specific venue. Next slide. Obviously, it's not the purpose of the IPS to cover that part, but may provide information to realize these steps. Obviously, if you would like to obtain that, this may be easier to realize if there are related standards that may assure that the information that are captured during the immunization event can be consistently move across the different steps, so that the information that goes into the registry may be used for updating the IPS. And this is possible if we have reference standard that can be reused during this step, like the ISO 5384 or the International Patient Summary. Next. So the idea is that if you can use this building block, the information about the vaccination, the next can be used either to include in the update the IPS with the relevant information that might be needed for generating a certificate, or for generating a different kind of specific kind of product of document like a vaccination certificate that might be directly built upon the IPS component, but derived from an IPS that includes the relevant information. This document can be next one, using appropriate transformation, can be used for generating artifact like sign a QR code that can be used for verifying the vaccination that are documented in the IPS or in the certificate. So next slide. So to conclude, the IPS, as described, is currently recognized as a common baseline for global sharing of health data, and this may include also vaccination. That's the reason why, for example, the IPS has been already used in different national or regional contexts, and also GDHP is I've selected that standard as reference standard for the interviewee workstream for promoting the global implementation of this standard for patient summary data exchange. The Global Digital Health Partnership is a collaboration of government, territory, government agency, and WHO formed to support effective implementation of digital health services. As Rob mentioned, another value of the IPS is that it's really a result of a collaborative effort of different standard organizations. So each of these standard organizations brought the knowledge and the input from their specific stakeholder, allowing to really improve the quality and the scope of this standard. That's the reason why we believe that the IPS may be really be used as a global foundation for building the vaccination certificate, as WHO DDCC is looking at, but also potentially for other kind of global document or data that might be exchanged cross-border or the global level. I don't know if there are any specific questions that Rob and I could answer. Otherwise, I will give the floor back to the. Oh, thank you, Garrett. Thank you, Derek. To Amit.
All right. Well, if folks have any additional questions, please include them in the chat. Otherwise, with that, Rob and Giorgio, thank you for that great presentation on the International Patient Summary and continuing our theme around collaboration. And so as we move to the last presentation in this session, our colleague Rajeesh Menon is going to speak on the digital infrastructure for vaccination open credentialing, DIVOC. And this is an effort that we haven't had a chance to hear about in some of the past sessions that we've put on through the consortium and earlier today. However, as we're talking about implementation, we'll have the opportunity to hear from Rajeesh about some real world experiences that he has the opportunity to share with us today. So thank you, Rajeesh.
Thanks, Amit. It was fascinating to hear all the different perspectives from the earlier speakers. So so as you rightly put, I'll probably use my time to actually speak about one specific initiative that I've been a part of and our implementation experience in one country particularly, my native country, India, as well as a few other places where we have actually tried deploying this credentialing system on the ground. So the topic of my subject is essentially an initiative called DIVOC. It stands for Digital Infra for Vaccination Open Credentials. Sorry, I'm unable to actually switch my screen. Are you able to see my screen though?
I am able to see it. It's just on the title though.
Okay. I'm able to switch over to my next slide. I'll try doing that again.
If that doesn't work, I can try to. Oh, there you go.
Oh, all right. Okay. Yeah. So DIVOC essentially is an open stack that essentially came into existence in the November of last year. It was primarily engineered through the efforts of some of our core architects of India's National Identity Program, National Health Stack, and the universal payment infrastructure that the country has been successfully deployed over the past 10 years. So about November last year is essentially when we have been talking to the government of India and looking at ways to actually support their national vaccination program, which was scheduled to actually begin in the first month of this year. So that's basically when we set about building this particular stack. So it was always designed to be made available as a public good. It's completely open source. It's available for any implementation partners or countries who are willing to adopt this. And the core focus was always to not build an end-to-end vaccination program stack. It was largely meant to address the needs of the vaccination last mile, essentially the activities that are necessary to drive the inoculation programs on the ground, have a system that can coexist along with the legacy supply chain systems of countries, and manage the entire flow, ultimately leading to the issuance of credentials for citizens of a country. So that's largely what DIVOC was meant to address. So during this effort, we took particular specific care in making sure the entire stack was designed as a completely modular environment. There are numerous specific modules specifically catering towards establishing registries, managing the vaccination workflows, managing citizen feedback and adverse event reporting. And last but not the least, the most important component being the issuance of verifiable credentials. So that's largely what DIVOC constitutes of. And these credentialing module of DIVOC was also built with specific open interfaces in mind. It was meant to also exist with, as I was saying, other legacy systems that countries may have in terms of managing vaccination workflows end to end, like as one speaker earlier spoke about DHIS2 in particular. So the idea was to have open interfaces that could work with some of these other vaccination systems, as well as make credentials issued through DIVOC available in any third-party consumer apps, whether they're travel or health wallets. So that's basically what the underlying principle of DIVOC was. And as I was saying, it's completely open source. It's a MIT licensed software package. It was always designed to perform at scale because our starting point was always in India implementation. So our views were specifically to cater towards vaccination rates that exceeded 9 to 10 million vaccinations a day. So we were very clear that the issuance rates of these credentials through the system had to perform at that particular scale. And specifically, DIVOC on its own is again based on W3C verifiable credentials. So it keeps in line with the privacy preserving principles of what W3C stands for, as well as some of the native principles that our national health stack advocated in the country through our government policies and so forth and on. Yeah. So as I was essentially saying, so it was based on W3C, essentially on JSON LD scheme. So we actually emit a custom JSON object as part of the issuance system. Recently, we've also made sure to make it available, having a FHIR object as well. We've modeled it on the FHIR SVC IG that was out a couple of months ago. So effectively, we have both of these two objects available in a digital form that any third-party system could access after due authentication. But that's largely on the issuance part. But at the same time, we opened up other services for verification of these particular certificates, both online and offline. Again, as one of the earliest speakers spoke about, our needs and requirements were catered towards low resource settings in LMICs. So we were very cognizant of the fact that we had to have functions available for offline verification of these certificates. So as you can see on the screen, what we've made available through our issuance system is a multimodal certificate output. It could be presented in a PDF form with a QR code, or it could be made completely available as in the custom JSON form made available through any third-party apps where the QR code could also be presented in their particular platforms. So distribution-wise, the services that we opened up through DIVOC is essentially meant to cater to these multiple scenarios, both on paper as well as multiple digital means. And again, in India's case, at least, the program was largely centrally driven. And at the same time, because of that particular nature of the vaccination program in the country, the certificate issuance was also largely a centrally driven subject. So the options that we had to cater to included making these certificates available in digital form as well as printed at these vaccination sites on the ground. So I've actually put a sample. I'm sure some of you probably would have seen a few certificates issued by the Government of India over the past few months. So these certificates are easily available through printed copies to citizens and handed over when they actually exit the facilities. Being a diverse country, we had to cater towards multilingual templates. So all of the certificates that we issue are available in native languages. So we have enabled around 22 languages wherein the paper certificate could hold the data set in various different languages pertaining to the different provinces within the country. And at the same time, what we have actually opened up in the past few months is we've enabled the verification services for these certificates, given that the government has already formulated policies around opening up the economy and travel, both domestic and international and so forth. So to keep up with that particular requirement, we open up these verification services. It's available again in a multimodal fashion. There is a web app from the government wherein these certificates could be verified online. All of these certificates are available for offline verification through the QR code. So any third-party apps using these verification services and the public key issued through our platform can actually verify these certificates and actually confirm. Through our specific implementation, we also hold a certificate registry in which we also hold certificate revocation lists. So we do keep an audit trail of all the different lifestyle forms of the certificates along the life cycle, whether they're fresh certificates or as well as even if they're revoked certificates. In India's case, at least, the government did take a specific position on issuing 2 separate certificates for the 2 dosing events. That was largely keeping in line with the specific policy of the government to support continuity of care on the ground, as well as provide citizens with a proof of vaccination record so that they could actually use it in between the dosing cycle as well. So the dosing regimen that we follow in the country are largely 2-dose vaccines. So for both dosing events, we actually issue 2 certificates. So there is a provisional one and there is a final one. And when the final one is actually issued, the provisional one becomes null and void. So the final one is largely the only copy that the citizen will have at the end of the dosing cycle. Yeah, so as I was saying, so the DIVOC payload is available in custom JSON. We've also made it available in FHIR recently. We have a strong culture of PKI-based digital programs in the country, so we have largely emulated that as well. So we have a public and private key pair that is used for the signing of this particular certificate as well as verification. So all of these certificates generated through the DIVOC platform in the government vaccination program are signed with a private key. The public key is made available through the government channels to all authorized verifier platforms. The payload in itself is designed to support the various printing needs on the ground. So the QR code that we actually have is a 2x2 inch QR code. It holds around 200 bytes of data within the QR code. We've modeled the data set of the DIVOC payload largely on the minimum data set requirements established through WHO DDC spec. So it's a fairly limited data set. The payload is compressed. There is a secure QR code which can be managed through by any third-party verifier platforms through the public key that is made available to them. And lastly, as I was saying earlier, it's designed to support multi-channel distribution. So a lot of our rural use cases in the country require printing ability on the ground. So many of these certificates being issued on the ground are actually printed and handed over to the citizens. But at least in the urban centers, there are quite a few government consumer apps in which citizens actually request access to for their certificates, and wherein a particular call is actually made to the centralized certificate registry. And after deauthentication of the specific beneficiary and the consent and his consent, the certificate is actually ingested into those consumer apps. So that's pretty much how we operate in the country today. We have also enabled in the last 1 month an API policy through which the other external consumer apps from the private sector could also make themselves available for this particular option and avail this facility, wherein they could also, using the same consent and authentication methods, be in a position to fetch these certificates from the central certificate registry and ingest them onto their particular consumer apps. As I was saying, so our Indian vaccination program did go live on Jan 16th this year. So over the past few months, we've actually managed to issue more than 250 million certificates, and we are on track to issue around 1 billion certificates given our projected vaccination loads by the turn of this year. To enable this kind of requirement, the DIVOC platform is one integral piece in the puzzle. In the Indian vaccination program actually has a legacy vaccination system. DIVOC is the certificate utility that resides within that vaccination system. So the moment any vaccination events are recorded within the source vaccination system, a call is made to DIVOC, and wherein the data set is actually passed over, and basis that particular payload, a certificate is issued using our issuance service. And subsequently, it's again, there are fetch-based services available to these third-party consumer apps, wherein they could actually retrieve these certificates from the central registry. Also, as I was saying, the certificate verification services are also available. So all of the API specs, the reference SDK for third-party private sector apps who would like to build verification capability in their apps is also made available through the government channels. And recently, we've also put up services for certificate correction, given the kind of issues, normal implementation issues that you'd find on the ground. So we've given an opportunity for people to actually edit some of their certificate content so that they could use it for travel and so forth. So there is a correction service that has been made available to them, as well as the flexibility to support both online and offline revocation needs of these certificates. We've been very cognizant of making this entire stack, this credentialing system or credentialing stack, available in a modular fashion and very standards driven. So we have consciously adopted W3C. Now we've actually also picked up FHIR. That's also in line with the national health blueprint that the government of India has been advocating. And for all inter-system exchanges, we are very focused on FHIR. So FHIR is the default messaging method that we actually use for most of our inter-system health exchanges. So we've also come on to FHIR. And scale-wise, as you can see, so India presents a very unique case of having such systems work at scale. So given the way we've architected the system, we are in a position to actually manage quite high vaccination payloads. And most of these services are also available through policies enabled by the government as well. So that's pretty much with India. And in the recent past, we've also extrapolated the same concept over to nearby countries in the region. So we have done a limited scale pilot with the government of Sri Lanka, and we are looking to scale it up to the rest of the country. And there are a few other implementations likely in North Africa and Southeast Asia in July. So this essentially is a summary of what DIVOC is and where DIVOC and the journey that DIVOC has been going through over the past 6 months. And lastly, everything about DIVOC, the two links that I've actually shared on screen actually gives you full access to our public documentation repository as well as a source code and our API specification. So absolutely feel free to browse through them when you get time. Yeah, so that would pretty much be it from my side. If there are any questions, I'd take it up, or I'll hand it over to Amit.
All right. Well, thank you so much, Rajeesh. And thank you actually to all of our speakers for taking the time today to share with the community. We heard about a number of different initiatives and implementation efforts happening in a number of countries. And so with that, my colleague Claudio Saccavini is also going to join us to help us with this Q&A portion of our segment.
Yes, thank you, Amit. We are a little bit later, but if there are some questions from the floor, please chat using the chat, because I see a lot of comments in the chat during the session, but there are also some answers to this comment, and so we can move on if there is other question or request of comments. If no, or waiting some comments, I have a very short question to the panelists, because it is very exciting to attend to this section, because are very incredible resources on the field of the vaccination certificates of global scale. I believe that is the first time that we have so different groups that work in the same direction to solve this problem. Is a very incredible situation. And we see that there are different approaches from US, from Europe, from India, from WHO. But I believe that during this year, we see a convergence of these different approaches, because traveling is so important, and we have to move from Italy to India, from Italy to US, and so on. I have a very short question for the panelists. What is, in your opinion, the crucial task in the next month to reach the goal of this global interoperability? Please answer this.
Yes, I can make a comment there. I think from a technical perspective, the verification of these credentials is a fairly simple task, and we can do that very easily across borders. The data models, though, are slightly different, and we still need to negotiate some of these small differences between what is required versus optional, and then the different semantics of all these FHIR profiles, and then the systems that don't use FHIR profiles. And as I mentioned earlier, terminology has been a little bit tricky. So I think that's the biggest thing we need to negotiate between all these different efforts.
Other comments?
I would agree with that, and particularly I'd echo Neelima's mention of terminology. I think that coming up with common terminologies that many or most of us can use globally is a very big challenge, but also, if we were able to do it, would be a very, probably the biggest thing that could help us overall achieve the levels of interoperability that we would like to do. So we need to continue to work very hard on that.
Claudio, I have a question.
Jürgen, please.
Oh, go ahead, Jürgen. Sorry.
Yes, related to your question, Claudio, from before, and the answer of Neelima. I mean, yes, there are negotiations about the differences between the approaches. They seem quite similar, to be honest. I mean, there are a lot of overlaps, but I understand the details are the problem. But how about the kind of the governance of all of this? What is it WHO the only entity which really could kind of span and overarch all of these these different credentialing activities? Do you think so?
Some comments to Jürgen?
I have just a general comment kind of with both of your questions in mind, if that's okay. This is Jan Flowers with OpenMRS and University of Washington. You know, from a global health in resource constrained environments perspective and looking at global public goods, I think one of the things that is really challenging is, you know, we can take these processes and these standards and like digital smart health cards and the work that WHO is doing and kind of look at that from the generalized standard way of doing something. But what often happens for us when it really comes to implementation and uptake of these particular standards and these particular processes is those things haven't been done in a LMIC first perspective. And so really, we kind of have to step back often and come at it from, okay, what are the real needs for this country? Because those countries, the maturity levels of their HIS systems are such a variety and so variable. And also because a lot of the context within each country differs between each other, that we find we have to actually modify those quite a bit. And that there's a lot of things that have been done here for, you know, Europe or US or Canada, that they're just not quite capable of fully doing that uptake for, right? And so, while I think I'm really excited about a lot of stuff I saw today, and I think there's a lot of ways we can incorporate that into the global public goods, I think for us from that perspective, we'll also have to continue kind of massaging these things to really make them work within the LMIC settings that we actually serve.
Maybe if I could add to that as well. Sorry, Giorgio, to cut you off. I definitely agree with Jen, and I think from my experience, and obviously this is my personal comments, not on behalf of WHO, I think the governance aspect is really the crux of all of this, because I think we can see there's clearly technological solutions that can solve the problems in multiple settings in LMICs and high-income countries. But the reality is that a lot of these standards themselves have also been developed in high-income settings. I mean, the people who write the HL7 standards, the people who write the IHE white papers are from high-income settings and work in high-income settings. And so if you want true global interoperability with equity in mind, you have to consider LMIC involvement from the individual software engineers, the individual standards writers, as well as the governments themselves willing to adopt those technologies. And I think that is very much not solved yet, which is also why as WHO, we definitely want to drive member state consultation to ensure that those perspectives, all those perspectives are taken into consideration. And I think, I mean, kudos to all the additional work that has been done through consortia, but I think as you can see from those consortium members, they are private sector driven. They are high income representatives from mostly Europe and North America. And that is not representative of the 194 member states that exist in the world, including technically failed states as well. And I think those, for true global interoperability, I think all those equity considerations need to be taken in place, and the governance to support that needs to be there. Otherwise, it's never truly global interoperability. It'll just be whoever can do it and has agreed to do it, which isn't always representative of the globe. So that's all. Thanks.
Please, Claudio, may I precise my question from before? Because I know the LMIC is, I was not so much going on the LMIC or developed country issue. I was more on the question, you know, are we now heading into some hundreds of bilateral negotiations between the Commission and US and DIVOC and India and the country 1, 2, 3, 4, 5, in order that we mutually accept these credentials? Or is there something going on which, you know, overarches that, for example, under the auspice of WHO or something? Because, you know, there are 250 million credentials now in India, and soon there will be 100 million in Europe, and maybe also 100 million in US and others operations. So I mean, they cannot be ignored. And shall they now all bilaterally negotiate if they accept each other technically and also legally?
Speaking from the US perspective, it's almost not going to be possible for us. As I said, the US government has chosen not to get involved at all at any level. And our coalition is basically a voluntary coalition of, a bunch of organizations that have their own goals and who I cannot speak for as representative of MITRE. I can't really speak for Microsoft, et cetera, et cetera. So it's really no way for us to engage in any sort of international governance framework.
Yeah, interesting comment, but I believe that we have to close the session because we are very late. And I believe that it's an incredible session. There is a recording of this session, but probably we need to make another session at the next 6 months to understand if this work make a convergence of the global interoperability or not. I thank you very much to everybody, and I also invited everybody to register to the VIP tours and for Thursday event of the newborn in IHE ecosystem, that is IHE Catalyst. Thank you very much to everybody.
Claudio, and not forget our next listening session on vaccine credentialing with Asia focus, which is on July 15th.
Yeah.
You're welcome to join because that's the next instance where we continue that topic. Thank you.
Yeah, thank you.